Hello, welcome to today's book talk. We wait for a miracle, healthcare and the forcibly displaced. This is a book by Mohammed Zaman, and we are hosting this event today at the Wilson Center. I am your moderator, John Thornmajuk. I direct the Refugee and Forced Displacement Initiative here at the Wilson Center. More than 55 years ago, U.S. Congress established the Woodrow Wilson International Center for Scholars as a living memorial to the 28th president, who was and still is the only president with a PhD. As a congressionally chartered think tank, the Wilson Center provides nonpartisan counsel and insights on global affairs to policymakers through deep research, impartial analysis, and open dialogue to inform policy. So we are a bridge between the world of academia and the world of public policy. The Refugee and Forced Displacement Initiative provides evidence-based analysis that translate research findings into policy impact. RABD aims to expand the space for new perspectives, constructive dialogue, and sustainable solutions to improve for policy that will improve the future for the displaced people. Our approach is informed by lived experience, stories, and narrative, and that brings us to today's topic, healthcare for the displaced people. The healthcare challenges faced by refugees and the displaced people are complex and multidimensional. This requires not only understanding of the drivers of forced displacement, but also analysis of the barriers to healthcare as well as innovative ways to address them. In the book, We Wait for a Miracle, Mohammed Zaman shares moving stories of people with lived experience that span across 7 countries to highlight the everyday struggles of refugees and the displaced people in accessing health care. And one of the authors put it this way: in this beautiful book, Zaman puts past statistics and stereotypes to write with complexity, urgency, and insight about health crisis facing displaced people. And this is a very timely topic. So today's discussion will feature the author, Professor Zaman, who will shed light on key messages of the book. And then we have 2 discussions. All the speakers will highlight the multifaceted relationship between the displaced people and the local community and how that affects access to health care. Second, they will also shed light on the neglected policy areas in this space that need visibility. And third, of course, talk about the importance of lived experience as told in this book and demonstrated by this book. And finally, of course, we want to take key lesson for shaping policy on this topic. And so here is the run of the show. I will kick off with the author in the first part of the conversation, asking him questions, and then the second part would be 2 discussions. One of them is joining us, Paul Spiegel from the Johns Hopkins University, and he will be speaking virtually. And Megan is here with us. And then that's the second part. And then the third part will be the Q&A session where we will receive online question or in-person question here, and then the speakers will address those questions. And then the final will be the key takeaway section, which we are all waiting for. What are the key takeaway from this and the solution? And so I will be strict online I will be strict on time as the moderator, and at times I will disrupt the show, sorry. But welcome to our online audience and those who are here, seated here at the Wilson Center. We have more than 200 online we have reserved, so thank you for coming. Now, the speakers, I will introduce each of them as I ask them questions. So I will start now with the author. Professor Mohammed Zaman is the professor of biomedical engineering and global health at Boston University. And he also the inaugural director of the Center on Forced Displacement at Boston. He has a PhD from the University of Chicago in chemistry. And here we are. Professor, welcome.
Thank you so much, Jonathan. Honored to be here.
So let's begin. You really wrote this book not from the as a professor, but someone telling the story of the real people. And so let's start with you. What interests you to write about forced displacement issues when your academic background is totally different? And maybe shed light on who you are actually in terms of your background, and then that will inform the discussion. So welcome.
Well, first of all, thank you everyone online and in person here. Thank you, Megan. Thank you, Paul. So I was born in Pakistan in 1977. Soon after I was born, Pakistan started to see a significant number of Afghan refugees come to the country, including in my city in Islamabad. So I grew up in a city which had lots of refugees, and I hate to admit it, that it was a pretty xenophobic environment. I mean, I think the people that I grew up with, people around me, were blaming Afghans for all of the social, political, economic ills of the country. And I think that unfortunately has not changed even to this day. The conversation in October of this year in Pakistan was again how to send Afghan refugees back, and even though it's been 40-something years and many of them were actually born in the country. So that's the context in which I grew up. It took me quite some time to figure out, as I got out of that bubble of environment, of how problematic many of those assumptions and statements were. So there was this prevailing notion that all Afghan refugees are bad except the ones that we know. Those are the good ones. Everybody else is not, right? So our corner street shop owner was a good one. Everybody else was not, and so on and so forth. You can imagine a similar kind of sentiment that we see in this country and many other places as well. So that has been very much on my mind. And as I went through my academic career as a graduate student, I wrote a little bit about some of the social justice issues. Even though I was in chemistry, I took classes in the Harris School of Public Policy. My advisor was very kind. And so I've had that interest, and I wrote in the newspaper and all of that. As always, there were issues, whether it was something to do with immigrants or refugees or Palestine or other places throughout, as we have known. But in 2009, I moved from University of Texas to Boston University. I was recruited to Boston University, and I sort of chose that I wanted to dedicate part of my own research, my writing, my teaching, to global health issues, specifically global health. And soon after that, I focused more on refugee health. You know, one of the things that happened in this journey is in 2015, I was at a conference at American University of Beirut. And the title of the conference was The Role of University in Post-Conflict Rebuilding. And it was a really nice conference. So I was invited from the side of engineering and sciences, but there were poets and philosophers, ethicists, historians. And it really made me think, why is it the responsibility of a university in Beirut or in Pakistan to only look at these issues? Just because by a simple accident of nature, Boston doesn't happen to be next to a place that has high number of forcibly displaced persons, doesn't mean that I don't have any responsibility, right? So I really then sat down and started thinking about what can my university do. I was already working in some of these things. We had already been working in some of the camps and settlements. And soon after that, at a consortium of universities for global health meeting, I met Paul for the first time a few years after that. But I had been thinking about this, that what is my responsibility? What is my role, both as an educator and as a researcher? And at that time, I started thinking about writing something that was also both self-reflection on where I come from, who am I, how do I think about it, and the problems that I was seeing broadly. One of the things that I wanted to mention in this book, and I tried to do that, was to go beyond the prevailing narrative. So if you pick up the newspaper today, you'll hear about Palestine, you might hear something about Ukraine, maybe depending on the newspaper, you might hear something about Sudan. But our ability to move on to the next crisis is so fast that we somehow think that everything else has become a sideline, an afterthought. And I wanted to challenge that. I wanted to sort of talk about people who we have chosen to ignore deliberately or because their attention span is limited. I also wanted to challenge this notion of who a refugee is, who a forcibly displaced person is. So one of the stories is about, one of the main themes is about communities in Pakistan who are stateless, who are never discussed in any of the conversation. These are people who are basically not moving, but the state has moved away from them. So their displacement is not because of their actual movement, but the state's movement away from them. So I wanted to sort of challenge that notion. I wanted to talk about people who are not moving because of conflict. So my focus on our colleague in Venezuela, from Venezuela in Colombia, is to challenge this notion that people move for a variety of reasons. The economic collapse, you can think of economic collapse in Zimbabwe, people going to South Africa, and similarly. And then in your home country of South Sudan, Jonathan, this question of what happens when people come back, right? And our international structure somehow is not fully equipped to handle that. And you may come back to a place that is in a worse state than when you left. And so I wanted to sort of look at these kinds of questions that are often not part of the conversation. It is not to say that the issue in Syria or Palestine or Sudan or Afghanistan or Myanmar is not important, but the goal was to basically think about different issues that are just as important. Their kids are just as important as my kids. Their lives are just as important as mine, but oftentimes our focus is limited in the current here and now kind of a moment.
Yeah.
And this was the goal.
Yeah, great. So, and this is a very, it set the context of the book because you are, again, telling real stories. For our online audience, again, the book is We Wait for a Miracle, the Healthcare and the Forcibly Displaced. So I want to go to the title, what is in a name. How did you come up with this? We wait for a miracle. And tell our audience what that miracle might be.
Yeah, absolutely. So there are two parts of that story. One is me as an academic came up with the title that the editor flatly rejected. He was like, absolutely not. What is this? So then he said, let's go back to your interviews. And so we spent time going through the interviews. And one thing that came up was this great sense of frustration, despair, that people are basically locked into the current status quo. They're unable to do anything. Nothing seems to be going that way. And this is a translation of an Urdu phrase where somebody said that only a miracle can get us out of the current predicament, right? It is not, we have given up on our friends, our society, the state, the international agencies. So this comes out of this sense of frustration, but also a despair that nothing seems to be working, right? And so people, of course, want to have a better life. People want to move on, but the situation is so depressing in many ways that there's hope only out of something that is supernatural, that is something that is miraculous, rather than the current state of affairs, which seems to be a dead end for many.
Great. And again, so the title came out from living experience stories that people were frustrated in terms of accessing to the service that they need. In the book, and one of the fundamental premises of your book is based on three key factors that influence access to healthcare by the displaced people. You talk about the role of trust or lack of it. You talk about social network. You talk about the regulatory environment as the three main factors. If you could expand with some example, because again, the real people, you told their stories and how these three factors actually play out.
Absolutely. So we often think of in simplistic notions that if we had more money, we would be able to do this. And that in itself is true. But there's something more subtle, much more, I would say, specific that is needed. So let me first talk about trust. So some of this came again, some of our work in Lebanon. So after the Syrian civil war started, there were communities of Palestinians who had been living in Lebanon for quite some time, and Syrians who came in. And they would go to completely different health services. So the Palestinians would go to one kind of health services, and the Syrians would go to another, even though they may be close by or they might be living next to each other. So when we dug in a little bit more, it was largely because of this relationship of trust, right? So the Syrians had these very elaborate mechanisms with taxi drivers and borders and all of that, and they would go to their village to find medicines from the pharmacists that they knew. And again, you see these kinds of things over and over again. And in many ways, we also see this in our own lives as who do we go to? It's a relationship of trust. It's that relationship that is important, and oftentimes we don't think of that. So trust plays a role. So, and we saw this in pandemic, that people would trust some sources and not trust other sources. People would rely on some pieces of information and not rely on other pieces of information. So this is an important part of how people navigate, especially people who are under tremendous threat, anxiety, frustration, and in many ways are very vulnerable. So this question is very important of how do they access both information and resources. So we spend some time thinking about that. It's also, for example, the case in Pakistan with stateless communities where they're harassed by police and the state. Who do they go to? It's people they trust. It's institutions they trust. And it is that trust has an important role. That trust in many ways goes into their social network, right? And we see that people who have some kind of a social network are able to do better than people who are often in this kind of an isolation and then don't have any sort of connectivity. I was talking to some colleagues, and this is also true in this country, who had worked in San Francisco, and they were telling me about the work that they'd done in San Francisco of these Cambodians and sort of Vietnamese and Chinese communities who did not grow up in any church, but they started going to specific churches just because there was a social network that allowed them to access resources. It was not that they had a relationship with that faith. It was largely because there was this ability to navigate the system through the social network, right? And we see this in many countries, and that social network is there through technology, WhatsApp and Facebook and others, and also through word of mouth. And it's oftentimes that social network that tells you where to go, where not to go, those kinds of things. So in Colombia, for example, it was quite common for us to hear these stories about people going to a particular hospital at a particular time and not at other times because of that trust and social network that told them that so-and-so works there who is going to be kind, and don't go at another time because they're not going to be treating you well. You know, you can create all the laws, Jonathan, about access to healthcare and all of that, but in that vulnerable moment when somebody is at the clinic, you are not going to question that, oh, this is my right. If somebody does not want to give you that access, you don't have the ability to go to the court and say, look, I'm going to exercise my right. There's that tremendous power dynamic. And to navigate that power dynamic, you really have to have social network information and also trust. But you remember that these things can also be problematic. So some information in social network can actually be problematic in situation. For example, we see this in misinformation. We've seen people going to unlicensed practitioners and faith healers. That comes from some of these things. And the regulatory environment is actually something that we often don't pay attention to. How countries and communities actually regulate, thank you so much, access. So the presence of poor quality medicines, the prevalence of faith healers and unlicensed practitioners that many people would end up going to, and sometimes the state looks the other way, sometimes it cracks down, and you can see almost a sine wave of things of how people respond to that based on that regulatory environment of how things work out. So all of these play a role in terms of access or lack thereof. But one has to recognize that these can also be challenging, or in worst case scenario, be even weaponized, right? So you can sort of take people out of their social network if you really are going to make their lives very difficult, or you can really break those bonds of trust. So one has to navigate that in a very sort of a careful manner.
Thank you. And maybe to give you a little break, I want to go to Dr. Paul Spiegel. Thank you very much for joining us virtual. I know you had to adjust, and you have to adjust your schedule. Dr. Paul Spiegel is a Canadian physician and epidemiologist by training. He's one of the few experts in humanitarian health in the world. He has more than 30 years in this field of humanitarian emergencies and issues of that nature, including forced migration. And so we are delighted that you join us. And maybe a few reflections on what Mohammed just said about the key factors that really influence the access to healthcare by the displaced people. And as a practitioner, both a practitioner and also an academic, you bring that perspective. But to also, the book talk about how health, refugee health, has often been viewed through the lens of humanitarian emergencies, which we tend to neglect some of the healthcare challenges faced by the protracted refugees. And maybe how do we go beyond this simplistic thinking, which is we thinking of emergencies, but not going beyond that. And as now, as we know, forced displacement is becoming increasingly protracted. And so, how do we think beyond this, as highlighted by the book? So, welcome.
Thank you very much, John Ton, and thank you, Mohammed. Congratulations. Really, really exceptional. And I've been reading about Raphael, Henry, and Seda in the book, and I love the way that that you've been using the stories to be able to really get across your key points of the aspects of trust, social network, and the regulatory environment. I would say first at the beginning, some of the long experiences that I've had in terms of people who are forcibly displaced, whether they're refugees, internally displaced persons, or stateless, is that it relates to the trust. There's an incredible amount of discrimination against these people to begin with, just because of their, quote, status of being a refugee, an IDP, a stateless person, and therefore they're already discriminated against. And then there is a tremendous amount of misinformation that is occurring. They are the ones that are spreading disease. They are the ones that are bringing crime, where the data really show that generally that's not the case. And that, for example, in some of the areas and the studies that I'm aware of with refugees, usually in the economic environment, particularly in the local area, actually improves when refugees move there for a variety of reasons, both because of the refugees' industriousness. I mean, we saw Rafael from Venezuela as a lawyer. People perhaps mistakenly think of people who are forcibly displaced as dependent people on aid, but that's really not the case. They have an incredible amount of skills that they always provide to that host community, who are often better off because of that. So I was just some quick reflections on the book. The aspects of social network, we see this consistently as well. Often people do move not as individuals. Sometimes they do, but in many situations they move as communities themselves. And so some of the social networks in that community continue. But over years, we've also seen social networks can become frayed. Often men and women are not able to work, but in some of the more traditional societies, women continue and have access to different types of education, to international communities. And so their outlook may change. Men can often feel emasculated. And so the social networks within communities and within families can change. But what has consistently been a problem, and then I'll just get on to that last question you have, is that in many situations, refugees, internally displaced persons, don't have the same access to both information but finances. And I would say some of the big changes that we've seen over the last decades, but need to be much more reinforced, is the idea of seeing how refugees or let's just say forcibly displaced persons can be integrated into host communities, where both the host community and the forcibly displaced persons can benefit. And that's both in terms of economics, but it's in terms of both education and health. And so no longer do we recommend that, if it was ever recommended, that you have a camp and that you set up parallel services. Rather, let's improve services for all of the communities, the host populations, and those that are displaced. Let's try to combat a lot of the misinformation. Thankfully, now there really is more access to social media and more information that has both been a blessing and, as we know, a curse in many ways. And I'll end just by mentioning this term of the humanitarian development peace nexus. Some people find it confusing, but in essence, in an emergency and in a protracted situation, we should not just think about what we're doing immediately, but think of the long-term goals of the development of where these populations are. So that, and that means working with development actors, working with humanitarian actors, and of course the governments, to improve a situation and thinking long-term and not short-term. And it's particularly important because of climate change and because of other areas where we're going to see more and more disruption.
Thank you. And I will get back to you, but I think you made an important point here, which I want to go to Megan. The women and children are a segment of displaced people that are disproportionately impacted by forced displacement and especially the access to health care. And Megan Daigle is the senior fellow with the Humanitarian Policy Group at the Overseas Development Institute. And she is here on a visit in Washington, D.C., and we just took the opportunity and glad that she was able to do this. And I would thank our Maternal Health Initiative because the connection. And Megan focused broadly on gender, sexuality, race, and disability in humanitarian contexts. And she has done research in these areas. And Megan, as we discussed a few days ago, lack of access to healthcare affects women refugees more than any other group, and especially pregnant women and mothers with newborn. What should be done differently to address the need of this specific group that are not always, at the radar, and then you can talk about again, the perception that sometimes people think that when, especially family, the family situation, people think that life could stop when people are displaced, but they do their things also as everyone else. So, welcome.
Thank you. Thank you to the Wilson Center and to Jonathan for the invitation to be here today, and thank you to Mohammed for this book. It's beautifully written, and it's a really needed counterpoint to, as we were saying, the narratives about forcibly displaced people that we see so frequently in the media, in policymaking, and elsewhere. I'm going to be speaking today to two main bodies of research, and both are on sexual and reproductive health and rights. Firstly, in Colombia with a Venezuelan migrant population, and also in Lebanon. So there's a lot of synergies here with the book and its content. We did interviews and focus groups with Venezuelans in Colombia, and then a mixed methods survey with Palestinian and Syrian people living in Lebanon. And there's so much resonance here in the findings around the various and overlapping kinds of barriers that people face. And I think what I've heard already from Mohammed and from Paul about social networks is really so key, because what really emerged from our work is the fact of existence of services, or even entitlement to those services, is really not enough to ensure access. We see problems of uptake when services do exist. Awareness, the fact that the service exists and people are entitled to it doesn't mean that they know about it or how to get to it, but also so many other barriers. And I'm going to talk about some of those now, because as you started off by saying, the barriers facing particular groups of forcibly displaced people, and especially people facing multiple forms of marginalization, are particularly intense. And our research really pointed to the importance of stigma as a really key barrier. And there's particularities with that when we're looking at sexual and reproductive health and rights. There's sensitivities and taboos around talking about sex. These are culturally specific. They're more intense in some places than others. But we also saw discrimination, as Paul mentioned, against lots of different groups, including and on top of anti-refugee sentiment. Gender is really key, and restrictive gender norms. Women and girls face this in many different ways. Women and girls are the likeliest to report positive experiences in accessing sexual and reproductive health services, in part because they're the target population. They're who these services are designed for. But it was very notable that the people who had negative experiences were usually trying to access forms of care that were stigmatized and that were the subject of restrictive gender norms. So things like contraception outside of marriage. Also things like access to safe abortion care and tubal ligation, those kinds of things. But anything that countered people's understanding of the way women and girls should behave, saw them experience really intense discrimination, refusal of services, and other kinds of barriers that had a really wide-ranging impact. I also want to flag, though, that there are, sexual and reproductive health applies to everyone regardless of their gender or sexuality. And we saw LGBTQI plus groups really struggle to access the care and services they need. They were not seen to have sexual and reproductive health needs, and services weren't tailored to them. They were often shut out or poorly treated. And this also applies to people with disabilities who've been historically denied bodily autonomy, had choices made for them. And we see that particularly intensely for people with disabilities who are displaced. And all of this is often related to ideas that we have about who should and shouldn't have children. And that applies to those groups, and it also applies to refugees and other displaced populations. We really noticed that when people reported a negative experience, they overwhelmingly indicated they felt they were treated according to how they were perceived, with very little or no care for equal treatment or treatment according to need, which you think should be the standard in health. And I think the big thing I want to highlight here is the interconnectedness of health with all other areas of life. The impact beyond mere health, and I don't say that lightly. Health is obviously very, very important. But our respondents, and women and girls especially, people with diverse sexual orientations and gender identities especially, spoke to the impact not just on their physical health, but on their sense of self, on their feelings of dislocation and alienation, and linked it back to dehumanizing experiences they had trying to access health. They've talked about feeling forced into a passive role, and this was particularly true for women and girls. When they tried to access care, they found low levels of agency, self-efficacy, and bodily autonomy. And this was true even when they reported a positive experience, which should be really troubling. And obviously in the area of sexual and reproductive health, any lack of agency should be really troubling, and raises the prospect of different forms of harm and violence that people can experience in these spaces. And it really comes down to their well-being. And I think Mohammed's spoken very cogently to this. But we're doing some research in HPG on this as well, on well-being, where humanitarians tend to concern themselves with bare survival. But we need to be thinking much more about what makes life livable. Aid users find humanitarian response dehumanizing. The services that they receive in the field of health, when they can actually access them, are also deeply problematic and leave people feeling even more alienated and dislocated than they had. And this is counter to the principle of humanity as it's enshrined in the foundations of humanitarian response, but also like the wider sense of solidarity with people living through crisis that inspires people, broadly writ, to donate, to support humanitarian response. And I think for me, the point I want to make is that maternal health, neonatal health, sexual and reproductive health, these are not just technical issue areas. They're a question of commitment to gender responsiveness. They're kind of a canary in the coal shaft for emerging, what we're calling feminist approaches now. And they really highlight the specific exclusions and the layered, compounded exclusions facing people who are marginalized on account of their gender, their sexuality, their disability or impairments they face, as well as racialization and their refugee status. And looking at this through a lens of well-being, this is an ethical obligation for humanitarian responders, and one that they're currently failing to achieve.
Thank you. And Mohammed, I'm coming back to you on your reflection on what Paul and Megan just said. But in the book you wrote, and I quote, our inability to provide adequate care is not simply because of lack of funds. It's also because of our own biases, racism, and ill will. And I think some of the barriers mentioned by the two discussants. But beyond that, what do you really mean?
Yeah, thank you so much, Paul. I must admit, both Paul and Megan have spoken very eloquently, and their analysis is right on, and I really appreciate that. Let me first comment on one thing. You know, the three main characters in the book are not just characters. These are extraordinary people as I got to meet and learn from them, but they're also caregivers, right? In their own limited space, they are both, of course, in need of financial support and otherwise, but they're also providing care in different dimensions, whether it is legal care, whether it is social support, or whether it is taking care of your family. And I want to again challenge that notion as well, that a refugee or displaced person is this hapless individual somehow only triggers this idea of pity in our minds, right? So in many ways, the book is written to myself to really challenge the notions of how we think about others. So now let me come to your point that many of our prevailing notions are actually quite racist. They somehow assume that a refugee is incapable of taking care of others, or the fact is that we sort of stereotype or create a caricature in our minds of these communities. Paul has already said that there is strong data demonstrating that refugee communities actually tend to do better economically, but I think there's also a bigger issue here that we have to think about is that how do we imagine, if you ask, I teach a course on this, if you ask who a refugee is, who comes to mind, right? I mean, we can all do a thought experiment. And many of those ways, those caricatures that we would have would often be driven by media and pictures and all of that, but some of it would be actually quite racist if we want to acknowledge that. So it is not just the issue of giving more money, it's also confronting our own biases. And within that, we also have many challenges. I mean, now in the current moment, we also think who is worthy of our own support. So somebody who becomes a refugee from Russia would be low down on our list, not because they're any less deserving, but because of our own imaginations of who's deserving, who is a refugee, who is a model refugee. And then people have written about, then are certain expectations that they should be grateful for our kindness, right? So people have written beautifully about ungrateful refugees, that somehow, and this happens all the time in Pakistan, that there's a sense that somehow Afghans are ungrateful to what great services they have been provided. So we really have to confront that. It is not, of course, finances are important, financial support are important, but some of our deep, and I would say problematic notions affect how we think about it. Paul mentioned this issue of parallel versus sort of integrated care. In many cases, the way, and I completely agree with Paul on this idea of improving integrated care, but many times the idea of integrated care also fails because the local community is not taken care of, right? So they would say, well, so we hear this all the time that, oh, I get these medicines made in India or Jordan or Egypt, and why do the refugees get medicines made in Germany, right? And so there's that tension that exists between the local community and the refugees or aid agencies, and that leads to all kinds of these new challenges as well. But we really have to ask ourselves of who do we imagine the refugee to be and how do we think about those?
Well, thank you. And we are zooming into the section where we'll talk about actually the solutions. But for our online audience, please send your questions to Joshua Peng, joshua.peng@wilsoncenter.org. The chat function on the web is off. So if you could send your questions to joshua.peng@wilsoncenter.org. Thank you. You talk about the models of healthcare system in this, and I want to bring Paul in here. Paul has to leave too at 11. And the integrated part, the integrated aspect of the healthcare system, you talk about not refugee health should not be separated from national health. They should be integrated. I wonder how would an integrated healthcare system will look like. And this is a question that all of you will respond, but let's talk. Let's start with Paul. What should an integrated healthcare system look like, and what that mean in terms of relationship between the host and the displaced people? And the displaced people have IDPs, the stateless, and the refugees. These are different categories. How should we go about addressing the health need?
Thank you. The answer, as always, is it depends. There's not going to be a one-size-fits-all, particularly because in each of these countries, the healthcare systems are so different. So if we look in a place like Lebanon, which is very, very highly privatized healthcare, that's going to be very different than in Uganda, where it's much more public. And I think they have a very good example of how, with the South Sudanese refugees and many other refugees, but let's look at BDBD, which is part of the book that for Henry, is that the government has actually, when refugees come over, they don't put them into camp-like situations, but rather they call them settlements, but they're more like communities. They have land to be able to work on and to be able to grow. So therefore, they're immediately less dependent on the either the government or the international community for food. And then they're integrated for the most part into the government healthcare system. And with all the positives and negatives of that, because in many of these situations where refugees or IDPs are located, they're in very remote areas where the systems may not always be as strong, obviously, as the capital. So I would say that's one area. One aspect is to look at the context, and those, let's say, perhaps are some of these extremes where you've got Lebanon very privatized, a bit more complicated. You've got Uganda that has a good system and they're able to. You also have some other areas where the system is hardly functioning, and therefore, as I think Mohammed was saying, we see a lot of problems, particularly in the past, but still where the displaced persons are getting better care than the surrounding communities. And that's really a problem because in terms of both equity, but also it increases resentment amongst the host communities and those that they are hosting. And we want to avoid that as well. So I think in many ways, what we've been trying to do is to try to remove to a degree the status, meaning you're a refugee, stateless, IDP, and your host population, and rather look at the vulnerabilities within an area of anyone, no matter what their status is, and try to develop and give proper care. I would say, maybe just because of time, I'll just say easier said than done. And one of the biggest issues that comes up consistently, and we don't have a very good solution, is the finances. So how do we pay for this? And at the beginning, maybe the international community can come in and support the local governments to be able to provide care. But in the long term, we see money going towards the crises that are either newer or in the media. And so in these protracted situations, there's less and less money going. And ultimately, it may fall on a government that also does not have a lot of money to be able to continue these services in the long run. So financing and ways to try to improve financing and make it equitable, both globally and then at a regional level, are really important.
Well, thank you.
Thank you.
Megan, if you pick up from there, what should a holistic approach to health and with the gender aspect of it, what has always been neglected to be factored in?
Mm-hmm. Well, I think I'm going to go back to, what Mohammed has said about trust and the importance of trust. And I think a lot of our findings centered on how to, first of all, leverage where trust exists and build it where it doesn't. We looked a lot at the potential of community-led models of care, at demedicalizing some kinds of care where it might be better served by being part of the community rather than in formal health spaces. And these are ways that people can really work with and get around some of the barriers they were encountering as they tried to access healthcare, to make it part of more holistic approaches, one-stop shop centers where you can access all kinds of different things you need. When it comes to women's health and sexual and reproductive health, is no one wants to walk through a door with a banner saying, come here if you need contraception or et cetera. So packaging it together with other community-led and community-based services has a lot of potential. Self-care also obviously gives people a lot more opportunity to exercise agency and control. And then I think, again, going back to Mohammed's comments about racism, that kind of reflection by humanitarian actors and healthcare actors is really, really needed to look in the mirror and understand what role those actors are playing in perpetuating barriers. There's a lot of interesting work out there on attitude transformation. IPAS has done some really interesting work on that to help actors of different kinds understand the way that they're perpetuating stigma and prejudice in the work that they're doing. And I think being willing to engage with a rights-based approach, and that's controversial in humanitarian spaces, where if anything, we're sliding back towards really purely needs-based approaches. And intellectually, I would thoroughly argue that the two are not separable. But rights-based approaches are what will get us to a place where we understand that treating someone as purely a physical set of symptoms is a dehumanizing thing. And moving past that means recognizing the need for them to have agency, to feel in control, and to have their say in what they want to happen matter. So I think, a willingness and to not shy away from rights in this space as humanitarian actors and as health actors is really, really key.
Thank you. And so, Mohammed, I'm bringing you back. You really talk about the lived experience stories. You spend time with these characters. They are not characters in the sense of a fiction. These are real people that you spend time with, and you bring in the role of digital technologies in accessing healthcare. So, building on what the two said about the healthcare system and what you wrote, what actually the role of technology in bringing solution, and what should we be concerned actually about the role of technology?
Jonathan, this book in many ways is a product of digital technologies, because what ended up happening was that as I was visiting and interviewing, COVID happened. So I had to rely on digital technologies to record interviews and sort of go back to them. So in many ways, the narrative was built because people said, oh, I met my brother so-and-so, and then I could go back and say, did you meet your brother there or not, right? So it allowed for a more conversational tone to occur because of the nature of digital technologies. Not to say that COVID wasn't an awful episode, but it allowed for a different mechanism to emerge in my own writing because I had sort of a different set of access. There are two or three things here. Again, going back to the point Paul made, context is extremely important. In South Sudan, the people did not have the same access to cell phones or smartphones as they did in Colombia. So assuming that everybody is on WhatsApp and everybody has a cell phone is just not true. And what I learned, and I talk about this in the book, this information can be weaponized. So many of the cell towers got destroyed during the Civil War, right? Whether it is deliberate or not is a separate story. But the fact is that digital technologies is not a one solution for everybody, first of all, because there is tremendous inequity in many parts of the world. Second, you have to recognize that ethical issues are often viewed as a sideline, right? So, for example, if you are a refugee in a third country and you lose your data, who do you go to? Where are the authorities and all of that? Which authority is appropriate, right? We still need to figure out many of these important ethical questions. Increasingly, we are also noting that for migrants, for example, at the border of EU, the authorities, for example, in Croatia, would burn their phones, right? And that is tremendously problematic on many levels, but also has tremendous implications on somebody's access to services, to GPS, all of that. And there are many reasons they would do that, and none of them are good reasons, but I'm just telling you that tremendous implications. The final point I want to make is I want to pick up on Megan's point. You cannot take health in isolation, right? So if you go to Paul mentioned Uganda, if you go to sort of the northern part of Uganda, close to South Sudan, you'd find mostly the camps would have women. So men are either fighting or away. So now there are these people who have to deal with their health challenges, perhaps health challenges of their family, but also they're the caregivers and the heads of household. So you cannot separate the fact that somebody's health is a different thing and their ability to raise some money to take care of their kids is different, and them being head of household is different. You have to view that in a continuum. There, you have to really think about what is the role of digital technology. Can that allow them to have a little bit more agency? But does that also make them more vulnerable? So what I want to sort of tackle here is to push back against this kind of technophilia that we have, that somehow digital technology or all technology solves these pressing problems. Many years ago, I read an op-ed, which was really good, that said a cell phone is not a midwife, right? So do not think that a cell phone or an app is going to address the concerns of a person that a community health worker or a midwife would. And this was coming from somebody who was an app developer. So you have to put these tools in an appropriate place. They're tremendously powerful and useful, but they have to be within the context of a system and not necessarily a silver bullet for all our problems.
Yeah, cell phone is not a midwife. That's a good. Paul, I know you have to leave at 11, but we are come back here to, and I want to ask Mohammed first before Paul, because why should we care about these issues of people that are far away from us when there are citizens that are struggling within their countries to access health care? You put that in your book, and I think our audience would be able to benefit from why care about these issues. Why should we care?
So I think that's perhaps a philosophical question of who should we care for, right? Somebody who just arbitrarily happens to be born within a region, right? That is defined by borders of nation state, or do we care about other people because that's what makes us human, right? So that's a fundamental philosophical question that we have to answer, is who is worthy of our care? So in some ways, it is very natural for us to care about our family, our kids, our parents, all of that. But at some point, we also have to ask that, is our care have a ceiling that somebody who just happens to be born within a geographic region is worthy of our care and somebody else who is not, right? And so we have to ask ourselves perhaps this most fundamental question, that are we doing this as a pity, as a service to others, or are we doing this because this is what makes us human? So we really have to change it from this notion that we are doing it because we want to feel good about ourselves. That's the wrong way of doing it. You do it because this is a fundamental sort of tenet of what makes us human, not because there's some kind of an arbitrary connection with somebody who just happens to be born within a contextual regional framework.
And building on that, Paul, I live in the refugee camp in Kenya for more than a decade. And what you mentioned earlier about, host countries, in those host countries, the local hosts are even, their access to health care is worse than the refugees themselves. And what we need to do is to make sure we integrate this so that there's no resentment by those in the host countries. If you could speak about that as you look forward to the key takeaway, how should practitioners approach this? The International Development Organization, their programming and in their intervention in these host countries not to exacerbate any tension that has already existed.
Yeah, thank you. Assuming you lived in Kakuma, that was the first, when I was a very young doctor, that was the first camp I worked in a long time ago. And there, I think it was a good example where we just put in, international community comes in, puts up a parallel system. Even when I was there, and that was decades ago, the Turkana, the surrounding community, about 20% of the patients that we would see were from the local community because the care was much better than what they could receive. I think even there, actually, in Kakuma now, it's been one of the test cases, where there has been trying to expand and work with local communities in a much better way, in a much more thoughtful way. So I would say one of the things that we need to think about is really starting before an emergency occurs, is looking at preparedness and looking at readiness. And we do know that approximately 65% of displaced populations, particularly refugees, come from about 6 or 7 countries, one of them being where you're from, in South Sudan. So while it's difficult to be able to predict certain crises, it is possible to concentrate on South Sudan, Somalia, Afghanistan, and a bunch of other of these countries that have been consistent, DRC, Democratic Republic of Congo, that have consistently had instability. And there, I think we can do things quite differently. We can prepare ahead of time. We can early on look at the existing health systems, at least at the district levels, of where they may be going, and working on ways to be able to, again, if we're talking about health, working on ways, but education is the same, working on ways to do a much better, stronger way of integrating that will improve the health system for the local populations and the education system for the local populations and those that are displaced, but also thinking about a broader area. Mohammed is an engineer, and thinking about water, thinking about sanitation and other issues that we can make improvements, working with governments to think, where do they see their own population moving and growing, and can the investment that comes with conflict and displacement, can that investment from the international community also be used in such a way that it can benefit that government in the future? I think many of us have seen, sadly, refugee camps that, in the end, thankfully, if and when refugees do return, they're just wastelands, as opposed to being used for the host community if they were planned in a more thoughtful manner.
Oh, thank you. And Megan, picking up from there, I want to ask we talk about possible solutions, areas of improvement. Bring the role of the importance of lived experience when people tell stories of real people, as Mohammed has remarkably done here, pointing to one of your research, moving forward on gender, livelihoods, and financing. There is this quote that I got out from that. You don't need to go one by one, but it's a general concept. Cultural, informed, and consultative approaches are critical to engage with displaced people, live experience, and make a local case for change. I think Mohammed went here beyond statistics to put the human face behind those numbers. And that's oftentimes missed. People talk about numbers and labels and forget about the real human lives behind those. So shed light on that.
So when we're talking about telling stories, I guess I'm going to tell you a story because storytelling is something I've been committed to throughout my research career, and I'm going to tell you about some of the stories we heard from people in the field, both health practitioners and crisis-affected people trying to access health. And what emerged was a real prevalent assumption that people living in displacement couldn't possibly want or shouldn't want to have children or to have more children. And like I said, this came from health workers, it came from humanitarian personnel, and it was something that was reported coming from them by crisis-affected people, displaced people. And sometimes these people meant well, and I'm not letting those people off the hook because it's paternalist and patronizing to mean well in that way. But sometimes it was also rooted quite explicitly in the kind of racism and anti-refugee sentiment that we've already heard a bit about today. And it resulted in practice in pressure, sometimes, in the worst cases, coercion towards things like long-acting contraception. and the closure or non-provision of pathways to things like fertility care. And this is where I think stories come in. We have these simplified notions of who people are. You're saying who is a refugee, and what people want and what matters to them, what makes their lives livable and good for them. And, as you said at the outset, Jonathan, life doesn't stop in a crisis. Real life continues on. Humanitarian response tends to look at maternal, neonatal, sexual, reproductive health of displaced people very, very narrowly, really through a frame of gender-based violence and like crisis pregnancy care. There's not a lot of room for family, for sexuality, for healthy relationships and consent. And things like decisions whether or not to have children are intensely personal and complex. We saw in Colombia there were changes in the ideal family size, but sometimes it was, sometimes people, restricted their idea of how many children they wanted to have. But sometimes it was the reverse, that family was something that made people feel anchored and alive and part of a community. And the same goes for understanding, like a wider understanding of people's sexual and reproductive lives, that social and cultural needs for belonging, well-being, affection, leisure, family, these are critically important, and they don't diminish, and they may even increase in crisis settings. And I think telling the stories of people and how that works for them in their lives brings back a lot of the complexity, the nuance, the reality of people's lived experiences that can be missing. And that's particularly true for complicated, emotionally loaded things like pregnancy and family, and that is so often missing. And I think, it is good and right that we bring back that complexity, but it's also important to the effectiveness of how we work, because I think, there's research out there that's, some by my team on narratives, and the fact that evidence isn't on its own often enough to convince people and to bring people around, to persuade. And stories help us do that. They contextualize it. They put that evidence in a frame that helps us to understand it and to understand what we should do about it.
Yeah, evidence is not enough. It's stories. This is the essence of Rabdi here at the Wilson Center. The approach we are taking is make sure it's not just the numbers that we're talking about, the human aspect, the lived experience, so that people relate. Unless you are a mathematician, we don't relate to numbers, but we relate to people's stories because they resemble something in our lives. So we're going to go to question. If you receive anything online, and prepare. But I'm turning to Mohammed and Paul.
I'm afraid I have to leave, Jonathan.
Okay.
But I want to thank you.
Say
and
one
thank
final thought,
Mohammed.
and then we will let you go.
No pressure.
What key takeaway? What is the call to action here, bring up by this book? What's your expectation?
There are many, I think. I mean, for me, I'm curious to really, maybe I can leave with a question as opposed to a call to action, to ask Mohammed what he thinks would be some of the next steps. Meaning, you have a book. I could imagine sort of almost vignettes or videos of some sort of emphasizing some of this. But what would be some of the next steps to try to move some of these areas forward, because it's vast, and I think there could be some really, I know there are practical and operational aspects that could come from this. And with that, I'm going to say thank you, and I do apologize for having to leave early, but it's really been a pleasure.
Thank you very much.
Thank you,
Thank
Paul.
you for making time. Thank you. Okay, bye.
Thank you.
Mohammed, you will answer that question at the end. But before, do you have question?
Yes, there's online, but
Okay. All right. Yeah, Dikshita. You can,
And if you can also introduce yourself.
yeah, briefly introduce, and then it goes straight to the question.
Hi, I'm Dikshita. I'm the Program Associate with the Maternal Health Initiative at the Wilson Center. I want to thank you for your incredible contributions today. And my question is, What are some tangible ways to promote resilience for crisis-affected people to be able to advocate for their own needs, especially for women and girls? For example, we know that girls' education is a powerful tool to empower girls and young women, but could you speak to maybe other solutions and interventions that can be implemented?
Thank you. Very brief and straight. Any online question you
Yes.
can ask on their behalf, Joshua?
Yeah. So first one from Sange Sering. In the case of Balochistan, hundreds of thousands of women and children have lost homes due to disputes between the Pakistani government and separatists. Displaced women are deprived of health care since they are considered family members of enemies of the state. How can international organizations, advocates, and policymakers help these women and women around the world touched by conflict-driven displacement who have lost access to health resources and recourse with their government?
All right. Let's start with those two questions. Megan, you want to start? Again, the two are related to women, the resilient, and then access by the women in particular, and then Mohammed will pick from there.
So I wish I had a straightforward and really practical answer, but I think a lot of what is emerging from the work we've done, and this is on what I've been talking about here today on sexual and reproductive health and rights, but also a wider program of work we have on gendered norms, is, well, the importance of packaging services together. Like I mentioned earlier, one-stop shop model, and I think that has a lot of potential to allow people to access things that they might not have individually sought out, but also to give them awareness of things they didn't even know to look for, which is key in a lot of settings. Like awareness is just not there of what people actually can access. So things like this bring it together and make people aware of things they didn't even know they had access to. And I'm going to come back to like comprehensive sexuality education, and because it isn't just about their sexual and reproductive health, there are knock-on effects on every area of life. And so understanding what people can access in terms of services, but also understanding how to assert themselves in relationships and understand what a healthy relationship is, has so many knock-on effects on their ability to earn a livelihood, on their ability to exercise voice and agency in every sphere of life. And I think, it's very, very new in the humanitarian space to think about a reproductive justice framework. But I think that has to be kind of key in how we understand the interconnections between all these areas and how we address them in a much more integrated way. So that's not very step by step, but it's some thoughts.
Thank you, Mohammed.
Yeah, so let me answer both of the questions in a similar kind of a structure. And I think in my own experience, empowering local communities is absolutely critical, right? Whether it is through local organizations or local community health workers and all. Let me first address the Pakistan issue and then come back to Dikshita's question. In any country where you have internal conflict or people are displaced because of actions of the state or other things, it can be very challenging for outside organizations to interfere. And there are many reasons, good or bad. That's a separate issue. But what often is missing is that there are local voices who speak up for the rights of individuals in that community. So the first thing I would do is to empower those and give those people the opportunity to speak up, right? When you're dealing with problems in Sudan, let the Sudanese tell you. When you're dealing with problem in Gaza, let the Palestinians tell you what the challenges are and not sort of do it from 10,000 miles. So giving the opportunity, giving the space to people who are able to speak with a sense of clarity and a deeper understanding is absolutely important. When we think of how can international communities help, we often think of sort of almost a colonial style intervention that comes in from the outside and doesn't incorporate local challenges, local ground realities, customs, history, traditions, and that creates more problems than solutions. So if you are really thinking about women and children who've been displaced because of exclusion or violence in any country, well, there are very strong local advocates who have been speaking up, and oftentimes nobody's paying attention, and they have probably some of the best ideas. So I think that's the first starting point. It's not to say that we shouldn't speak up or we shouldn't generate awareness or we shouldn't do ideation of new solutions, but first and foremost, let the local voices be in your driving seat, in your sort of guiding point as we think about that. And that's so. And then again, the same thing. So that's not just Pakistan, anywhere for that matter. And to again Dikshita's question, I think Megan put it quite eloquently and succinctly. I think one has to really think about local customs and norms and cultures as well, right? I mean, when I was growing up, it was a very certain kind of a family planning message. 2 kids with separation, and that was sponsored by, I don't know, whatever UN agency. And I'm glad that things have started to change, and it is much more about maternal health and sort of sexual and reproductive health. But I have lived in an environment where it was very top-down, very sort of, it doesn't matter if it's a man from Australia or Germany or Norway telling you that you should have 2 kids and this is how you should do it, right? And that one can imagine how problematic this is and how ineffective that is. Beyond the ethical part of that, that is just going to be massively ineffective. And people have looked at this in the context, and this is not even in the refugee setting, so just one can imagine. So really think deeply about cultural understanding, cultural sensitivity, and also I tell people the first starting point is humility. Start with a deep sense of empathy and humility. If you really want to do something, I mean, it cannot be with a sense of power or with a sense of feeling great about yourself.
Thank you. You have more online question?
From Sarah Barnes, also from the Maternal Health Institute. Each of the panelists has spoken on trust as an important aspect of IDP's access to healthcare. Research shows the value of community health workers and midwives, in part due to the trust they have earned within their communities. Can you speak to the use of community health workers and or midwives to support improved access and quality of care for IDPs?
Okay. Any other question on the floor? Community health.
Hello, I'm Camila Vargas. I'm a program associate at the American Bar Association Rule of Law Initiative, and I'm a former student of Professor Zaman at Boston University. So we've kind of touched on the topic of resentment among host communities, and my question is how you all can believe that international organizations and host countries can shift the mindset from resentment and the notion of why should we care to the sentiment that it is fundamentally what makes us human, and the idea perhaps that by helping our neighbors or community, we can help ourselves.
Thank you. Let's answer. Okay, one more, Mohammed.
Thank you very much. This is Imtiaz Ahmed, and I'm a postdoctoral researcher at University of Maryland, working on the resilient youth to prevent violent extremism at university campuses. So I'm really thankful for the insightful talks. I'm from Pakistan. I'll bring the context of Pakistan and displacement, and most of the IDPs are in the conflict zone, mostly bordering Afghanistan, and due to the the climate and due to the climate change as a multiplier. And they are denied of all the basic things like health, mental health care, education, and emergencies, which are the breeding grounds and factors for the violent extremism. Means the women and children in the IDP camps are denied of the mental health, and that is they become more vulnerable to the recruitment of violent extremist organizations. So how to break this vicious cycle of, you can say, so I would like to get insights from this. Thank you very much.
Yeah.
Thank you. I think we will answer those questions. Mohammed, let's start with you.
So let me start first with this. I'll go in sequence. The first question from colleague online. Community health workers are this really remarkable aspect of a health system. But at the same time, in many cases, at least in the stateless community in Pakistan that I talked about, there needs to be a kind of a regulation. So we know of many cases where midwives, for example, would practice things that are probably not okay and not appropriate. And oftentimes that goes and falls through the cracks. So I would say that just as we need to make sure that community health workers are empowered and are part of the community, we also want to make sure that they are also, one, held to some standard that is acceptable to everybody, and also given the opportunity to advance and to train and also be a part of that career, right? They cannot be doing this ad hoc. They cannot simply be just doing it because the goodness of their heart, because it leads to many challenges that we see. So all for community health worker, but also thinking more about how do we continue that. To Camilla's point, this is something that I've spent some time on thinking about, and we have to think. This is one of the arguments I make, is that this is not just a health problem. We need to engage ethicists and philosophers and engineers and historians. Let's do an example. We covered that in one of our classes as well. If, God forbid, you are at, let's say, a lake and there's a kid who's drowning, you would pick up whatever you could to help that kid, not because you feel pity on that kid, but because it is inherently human to do that, right? So we need to create that kind of inherent humanity in people, that if somebody is deeply distressed, you do that. Not because you'll get some brownie points or you'll do something else. Some people may, but in general, people will respond to take care of that kid and provide something and support them and be able to save their lives. So we have to dig deep into our own humanity and our own philosophy of why we do things and why aren't we doing things. It should not be transactional. It should not be based on some kind of privilege of this, that, oh, I'm doing this because I am powerful and they are not. It has to be much more inherent human connection that we need to develop. To our colleague from Pakistan, Imtiaz, the climate change point is, I think, is very well taken, but oftentimes it is much more complicated. It is not just climate change. It is climate and other kinds of things. And one of the things that I think we need to emphasize, well, two parts. One is mental health is an afterthought and often treated very poorly. But in general, refugee health or health of displaced persons is incredibly siloed. So we think of infectious diseases, something separate from chronic diseases, something separate from mental health, as if somebody who doesn't have mental health challenges cannot also catch cold or cannot have COVID, right? We somehow have thought of these things incredibly in silos, which has only created much bigger problems. The issue with mental health is that, one, it is still not fully understood how to navigate with that, and also we don't have enough trained people to really navigate some of these things. Goes back to the point that was asked online about community health workers who speak the language, who understand the context. I mean, there's data from 1960s and 70s in refugee camps that they were healthcare workers who didn't even speak the language, right? So you would go and basically parachute in completely different culture, completely different traditions. Now imagine something as intimate as mental health, and you want to have that relationship, again, going back to this issue of trust, and the person on the other end doesn't even speak the language, let alone anything else, right? So you really need to make sure all of these things are taken care of simultaneously, which may seem a lot, but eventually actually is also economically far more efficient than trying to create separate silos and separate structures.
Megan, pick one of those or all of them.
So to Sarah's question about midwives, and I agree with everything Mohammed has said about the importance of midwives and community health workers being understood as part of a health system and subject to the same sort of training opportunities and regulatory environment. And as I said before, I think they're community-based health care of all kinds, community health workers, midwives, some forms of self-care show a lot of promise for helping people get through the barriers they face in other ways, and especially get around stigma and achieve a greater sense of agency. They also, in difficult settings, present a lot of opportunities to expand reach. And I think the point to IDPs in particular is salient here. You know, one of the organizations I've worked with a lot in Colombia is Pro Familia, which is, you know, if anyone doesn't know, the largest provider of sexual and reproductive health services in the country. And they have traditionally operated brigades, they call them, of healthcare workers who travel out to more remote regions of the country. And so what they've been able to achieve with that is amazing for people who couldn't normally make it to a physical clinic. But like I said, I agree with Mohammed about the importance of it being a rigorous service that's provided, but also that we're clear that we don't understand it as a substitute or as a and off-road from the responsibility of state institutions and, in their absence, humanitarian actors to provide working pathways and accessible services. I think on the question of resentment and mindset shifts that are needed, greater awareness. I mean, we don't have enough research to hand already on social cohesion amongst host populations and displaced populations, but there's also often very little awareness between the groups about what each group is entitled to. And I'm thinking about our research in Lebanon, where we had Lebanese people saying, like, oh, the refugees get all this stuff for free. And then Syrians and Palestinians saying, every time I go to the clinic, the Lebanese people get taken in first, even if they arrive after me. And so, misinformation runs in every direction. I'd say both ways, but I don't want to be so, like, it's not as simple as that. And I think there's a lot of awareness raising to be done about what people actually are entitled to and what their experiences are. And that speaks to a lot of the themes we've spoken about today, about understanding refugees as dependent on services rather than having agency, about what they are and aren't entitled to, and what people resident in a setting are and aren't entitled to. And then on the violent extremism piece, I don't have an answer on this, but I think one of the things we need to understand and talk about more is masculinities in this space. Not in the sense that, that can be a panacea or explain things away, because obviously people become vulnerable to recruitment into these kinds of groups in response to a wide array of contextual factors. People are pushed and drawn towards those groups by economic exclusion, by feelings of helplessness and marginalization. And so, to point to masculinities isn't to say, oh, if only they could sort that out, we wouldn't have an issue. But I think understanding the interplay and how people seek opportunities to feel more capable, more in charge, more included, and more like they have somewhere to progress to, is really key to understanding the space.
Thank you. We are zooming in. We have a few minutes left, and maybe one more question that has not been asked. Be brief.
There might be something online as well, or no?
And is there something online, Joshua? No. Okay. So give him the last word in terms of question back there. Sorry, Mohammed. You are at the center.
Oh, thank you, Muhammad Ali, Islamic Relief USA. I could feel you were going to call on me because I'm your neighbor from Egypt, so I could feel the spirit of unity there.
I don't know.
Being neighbors. But my question genuinely here is, there are communities who are looking for a miracle, that have absolutely no hope. So my question would be to you is, what is their hope? Where is the path of opportunity for places or specific groups like those, like the Uyghurs in China? We look at Haiti, completely without operation. You look at places like Central African Republic that had ethnic cleansing. We obviously know what's going on in Palestine. So there are people who are saying, we are waiting for a miracle because we have been completely wiped off the face of the earth. What do you say to those people who don't have infrastructure, who don't have any structure whatsoever? Thank you.
And I'm glad I give you the last word for question, because you brought us back to the title of the book, which is a miracle in it. And so great. Mohammed, as you answer this question, and again we are zooming in, I want to bring back the issue of mental health and tying in here, because what is the role of religious faith? How do people cope with mental health issues, the displaced people? And from my own experience, there's different way. People, can just cling to their faith if there's no health care around. And one of the characters in the book here is Reverend Henry, whose brother returned from Uganda to South Sudan. And what did you find the role of religious faith in all of this? And plus the fact that miracle is used religiously quite often.
So let me answer the second question. I think one of the things that I learned many years ago of the role of faith-based organizations, one can criticize them, one can find many problems with them, but they're often there on the ground when nobody else is, right? So this is true across certainly the Christian faith, in certain Muslim charities, and also there are Jewish charities as well, in places where there wouldn't be anything else, and you'd find them in. So there is a role that they're playing. One can critique them, but that's a fact that they are there often on the ground in very complicated places. You know, oftentimes faith or spirituality is a vehicle by which people are able to manage very, very difficult situations, and this is what happened with our colleague in South Sudan. And you know, when I was writing the book, the end is not what I had imagined until the Reverend himself had a stroke and had to deal with this very complicated thing. And it was largely his own congregation that was able to raise funds. So there was this element of faith, congregation, social network coming together in a very unique way. So there's a great role. One of the things that, so I direct a center on forced displacement. One of the questions we want to ask is both the role of faith and the role of faith-based leaders in navigating this. So we want to have a sort of a workshop and a conference on that. For example, I'll give a very specific example. There are pastors in this country who are undocumented. How are they navigating these kinds of questions, both in their own congregation as they deal with an increasingly complicated asylum system, right? So how do they sort of handle this thing, both as leaders? So I'm not answering your question in the specific way, except for the fact that the faith leaders do play a remarkable role. We've seen that with imams in Nigeria. We've seen that with church leaders in South Sudan. We've seen that with sort of other kinds of faith leaders in other parts of the world. To the question about, you know, it's often very depressing to see that reality that you are. When was the last time anybody read anything on Central African Republic, right? Pick up any newspaper. It is not to say that their problems are any less important than those in Ukraine or Gaza or Tigray or anywhere else. Right? They're just as important as you and I are. And so there is that tremendous feeling of being left behind, and the world has moved on. Uyghurs in China, the Biharis in Bangladesh, the Bengalis in Pakistan, whatever. You can have a long list of people, and that doesn't end. I think the miracle in many ways is you and I, who know what the problem is and choose to ignore. So that's what I want. I want my life. I want to have some meaning in that sense. Whether I'll be successful or not, I don't know, right? But I think that is what we have to do, is to generate awareness, do what we can in ways that are truly meaningful, right? So we all bring a certain set of skills. So I am a professor. I have a research lab. I am not an NGO worker, so I can use some of my skills which are different than somebody who's going to roll up their sleeves. I'm not a clinician, so I should focus on what I bring in with whatever skills and sort of God-given skills I may have. So I think that's what we have. And if there are enough people, and there are really miracle workers. One of the stories in the book is about a positive outcome which was unexpected for the person in Pakistan, because she had gone to get her brother some treatment, and it ended up being a pathway to citizenship, which was much more viable. So there are these people who do these things. So I would say be the miracle worker yourself and empower others who are working on the ground, whether that is in Ukraine or in Gaza or in at the southern U.S. border. Some of the worst camps I've seen are on the Mexican side of the U.S. border. Absolutely just horrific places. And this is happening right at the nexus of this country. So I think there is that element in choosing to do that. The final thing is that these are lifelong things, and this is what I tell my students, that if they really want to do something, they should be committed for a very long period of time. Change is extremely slow, but when it does happen, it can make an impact.
Now we have 1 minute or so. Megan, what is the key takeaway that you want to tell the audience?
I think for me, it's first of all that there are always local organizations, there are always local movements doing this work. And they're what give me hope, but they're also what we should be seeking out as humanitarians to support what's already happening and that's responsive to people's needs. But my overarching point is that health, including maternal and neonatal health, reproductive health, even sexual health, is life-saving care. And that's a point I think we need to keep making in humanitarian spaces. And it's life-saving for everyone. that, you know, regardless of your gender, your sexuality, your ability, your nationality, and that for everyone piece is part of how we break down stigma. We make it not something that particular people are seeking out, but just a thing that people do. We can't pick and choose which elements of a health agenda are essential and which aren't. That just doesn't work.
Thank you. Mohammed, what's next, and what is the key takeaway from the book?
Well, so in many ways, what's next is to be able to think deeply about some of these things. And I want to pick up on Paul's point of what's next. I think thinking deeply about the role of narrative in broader science and broader research is absolutely critical. You know, you can have all the evidence you want, but that doesn't, well, first of all, there may be many problems with evidence. There's undercounting and overcounting and all of that, but narrative is absolutely important. How do you think about that? I also want to sort of bring more of these conversations where an epidemiologist and an engineer and a historian and a philosopher and ethicist and an international studies worker are able to think about this. So in many ways, intellectually, I've been thinking about how do you create spaces where everybody has a seat at the table. Nobody has a monopoly on solutions to be able to think about and reflect that, right? So, and I'm trying to reflect that in my own writing, in my own teaching, but also on the work on the ground. So the center that I direct, the associate director comes from Women, Gender, and Sexuality Studies. And there are philosophers there as they are mathematicians. To be able to create these spaces where we can understand and appreciate, and it's not to be anti-disciplinary, it's really to bring the skills of disciplines at a level where they can engage with each other, right? And we need to sort of break that mold, and I've tried to do that successfully or unsuccessfully, I think only time will tell, to be able to break that mold of how we talk about these issues, not from a lens of only one discipline, but putting humans at the center of that and then bringing the disciplines as needed. And I think that's what I want to continue on as we move forward.
Well, congratulations. The book is fantastic. It's storytelling, and I think one of the hopeful things that you mentioned in the conclusion is using the metaphor of a mirror. And I think that's the message we can all take away. As you just eloquently put it, the miracle is you and I. And so the metaphor of the mirror is cleaning the mirror enough so that we can see not just ourselves in the mirror, but also see those around us who have been invisible for so long. And I think that's where miracle come in. Let us clean the mirror enough so that we can see ourselves, but also those who are invisible. And the invisible are the displaced people, the stateless, the refugees, and how we can make sure they also have a better life. So to our online audience, thank you very much for engaging, and to our in-person audience, thank you, and to our speakers and the author, please join me in thanking them. All right.